So with all your permission, I'm starting the session for today.
Yeah.
May I have your attention, esteemed faculty and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. Good evening and a warm welcome to all the dignitaries present here. I'm Nang Himaki from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarnet serves as the digital partner for this event, hosted by the Indian Society of Pediatric Neurosurgery. The focus of today's session is the Pediatric Neurooncology II. So let's begin today's session, for which I would like to invite Dr. Naveen Mehrotra, sir, to take over. Kindly proceed with your talk, sir. Over to you.
Yeah. Thank you. Thank you, Himaki. So, a very good evening to all of you. On behalf of the Indian Society of Pediatric Neurology, I welcome you all for the monthly sessions which we are conducting upon the topics which are of interest in the pediatric neurosurgery. So today the specialty we have chosen is the pediatric neuro-oncology, in which we have a neuropathology session. I think last month we had a session on the diffuse gliomas, and this month we are having a session on the embryonal tumors of the CNS, central nervous system, and pediatric subscribed gliomas. The teacher will be Dr. Megha Uppin. She is an additional professor in the Department of Pathology at NIMS Medical Sciences, Hyderabad, and she has a special interest in neuropathology. I think I will now hand over to Dr. Megha for the session. Thank you. Dr. Megha, over to you.
Yes, sir. Thank you, sir. Are you all able to see my slides?
Yeah, I think we are able to see your slide.
Yeah. So thank you very much for the introduction, sir. I want to thank Dr. Naveen and Dr. Suhas and the executives of ISPN for this opportunity. So last time in the educational session for neuropathology, we have heard about pediatric type diffuse gliomas. And now we are going to look at circumscribed astrocytomas, which are predominantly seen in pediatric population, and that is why this is an important group of tumors which need to be known. I just want to request everybody to please mute their audios because there is some noise coming in the background. So because this talk is particularly meant for the students of neurophysics, I'm going to keep it very brief about the pathology. So I shall. So the first thing about understanding pediatric glioma, or for that any glioma, is its basic connotation with respect to diffuse and circumscribed features. So when you call something as a circumscribed glioma, it means it has a very well demarcated margin in comparison to the adjacent brain parenchyma, which can be very well made out on neuroimaging. And on imaging, this information is very important because sometimes there can be a morphologic overlap between a circumscribed and a diffuse glioma. And in such cases, the neuropathologist always likes to go back and find out more from the information which is given on imaging. Even on histopathology, this difference can be made out with a simple neurofilament stain. So here you can see the neurofilament that in a circumscribed glioma, this is a stain for axon. The axons will be absent because it is completely comprised of the tumor cells. Whereas in a diffuse glioma, you can see these axons running through the tumor, which indicates that the tumor is infiltrating the adjacent glial parenchyma. In a diffuse glioma, there are certain other structures which are seen, which is called as perineuronal satellitosis, which is circumscription of the tumor cells around the normal neurons. So on pathology also, it can be differentiated whether the glioma is a circumscribed or a diffuse one. So we'll begin with the types of circumscribed astrocytic gliomas, which have been mentioned recently.
I think there is a lot of noise. Is there, not, doctor? Are you able to?
Yes, I have requested them. Everybody to please mute yourself.
Please mute.
There is a attendee by Dr. Afreen. You are please requested to mute yourself. I think even the host can mute people. Himaki, can you mute the other people? So can I proceed? Dr. Naveen, can I proceed?
You can proceed, doctor. You can proceed. I'm able to hear you. Yeah.
Yeah, okay. So the entities which are covered under this broad group of circumscribed astrocytic gliomas are pilocytic astrocytoma, pylomyxoid, pleomorphic xanthoastrocytoma, Segas, chordoid glioma, and there are lesser known entities which are astroblastoma and high-grade astrocytoma with pyloid features. The last entity has received certain criticism, and that is why I will not go into those entities and I will cover the common entities. So the common feature of all these entities are these are less aggressive tumors. They have a very typical morphologic patterns, and that is why they can be identified by a simple H&E stain. And also they have characteristic genetic alterations which are common to all the subtypes of these circumscribed astrocytic gliomas. So we shall begin with the most common, and that is pilocytic astrocytoma, which is a CNS WHO grade 1 tumor, and it accounts for 40 to 50% of the circumscribed gliomas in the pediatric age group. And we know its known association with neurofibromatosis type 1, and it is a very location-specific tumors, the commonest locations being octochiasmatic hypothalamic region, the posterior fossa cerebellar tumors, fourth ventricle, and of course it can be there in supratentorial region in the hemispheric regions. So the imaging of these tumors is also very typical and shows a classic cyst with mural nodule appearance, which makes it easy to identify these tumors on imaging. As on morphology, the tumor has a classic biphasic appearance. So here you see the microcystic spaces which are surrounded by glial cells, and the glial cells in pilocytic astrocytoma show these elongated cytoplasmic processes which are termed as pyloid processes, and that is why this tumor is called as pilocytic astrocytoma. The characteristic morphologic feature of this glioma is presence of these Rosenthal fibers. So in this image, you can see these thick eosinophilic pinkish structures as well as some eosinophilic granular bodies, which is the clinching or the diagnostic feature of pilocytic astrocytoma. But it is not mandatory that EGPs are seen in every case of pilocytic astrocytoma, I think. Yes. Certain. I'm sorry. Yeah. I think the slides. Okay.
Yeah.
Another important morphologic feature for pilocytic astrocytoma is the appearance of giant cells and the nuclear arrangements, which is arranged as a pennies on a plate appearance. And this is a very important morphologic clue. Certain uncommon features can also be seen in pilocytics, particularly glomeruloid type of vascular proliferation. Now, everybody will remember that vascular proliferation is actually a feature of high-grade gliomas, but it can also be seen in pilocytic astrocytomas or the low-grade circumscribed gliomas. And depending only on this feature, these tumors should not be classified as grade 4 tumors. These tumors can also show geographic areas of necrosis sometimes because they are very large in size, and then they tend to overgrow the blood supply. Particularly for the posterior fossa pilocytic astrocytomas, oligodendroglial pattern is also known, but we have to remember that oligodendrogliomas as such a tumor is not a common feature in pediatric age group. So if you are seeing a dominant oligodendroglial pattern also, it is important to remember that it could be a pilocytic astrocytoma. Now, pylomyxoid astrocytoma was earlier termed as a CNS WHO grade 2 tumor and was included as a separate subtype of gliomas But now in this particular classification, it is included as grade 1 tumor itself, and it is called as a subtype of pilocytic astrocytoma. Now, as against the pilocytic astrocytoma, this particular tumor does not show eosinophilic granular bodies or Rosenthal fibers, and particularly the matrix is very myxoid, as you can see in this image, which can be highlighted on a special stain with Alshan pass. But it is important to make a diagnosis of pilomyxoid astrocytoma, because in comparison to the pilocytic astrocytomas, these are known to be aggressive tumors with a high chance of recurrence post-surgically. So when the WHO CNS 5 criteria for pilocytic astrocytoma insist on the histologic features in the form of the biphasic growth pattern, pyloid morphology, low proliferative activity, presence of Rosenthal fibers and EGBs. And in a desirable criteria, we are supposed to demonstrate MAP kinase pathway alterations, particularly the BRAF fusion ones. The second common entity in this category is pleomorphic xanthoastrocytoma, which can be either CNS WHO grade 2 or 3. Again, are common in children and young adults. And the peculiarity of these tumors are they are superficially located in the cerebral cortex. And that is why the most common manifestation of these tumors is epilepsy. And these are a part of group of tumors which come under the category of low-grade epilepsy-associated tumors. Now, as the name goes by that it is a pleomorphic tumor, you can see that the tumor cells show a very high cell size variation. There are a lot of bizarre giant cells which can be identified. They can be associated with presence of eosinophilic granular bodies. And to the extreme right, the arrow shows a typical cell which is described as a xanthoma cell. So this is basically a glioma with bizarre pleomorphic morphology and presence of occasional xanthoma cells, which are the essential criteria for diagnosis of these tumor according to the WHO CNS 5. Low-grade gliomas can also show perivascular lymphocytes, which is an important clinching morphologic feature. And the PXAs particularly can show a lot of reticulin deposition, which also helps in making a diagnosis of this tumor, since this can have morphologic overlap with epithelioid glioblastomas. Now, apart from the routine glial markers like GFAP and S100, the peculiarity of PXA is it will also be positive for CD34 immunostain and can show bright expression of BRAF V600E on immunohistochemistry in 60 to 80% of the cases. If the same tumor shows increased in atypical mitosis like what is being shown in this particular picture, if the mitotic count is more than 5 per 10 high-power field associated with without necrosis and presence of CDKN2A, 2B homozygous deletion, then the same tumor is graded as WHO CNS grade 3, which are known to be more aggressive in comparison to the grade 2 tumors. The next in line is subependymal giant cell astrocytoma. I think everybody very well identifies this tumor as a very well circumscribed tumor in the lateral ventricles, which arises in the background of tuberous sclerosis. And presence of tuberous sclerosis more or less is mandatory for the diagnosis of SEGA. These tumors are characterized by these large polygonal cells which resemble ganglion cells or gematocytes with eccentric nucleus and a prominent nucleolus. And they, being a part of astrocytic tumors, will show very bright expression of the glial fibrillary acidic protein as well as neurofilament. These are grade 1 tumors and do not show any evidence of ATP as such. In few percentage of tumors, ATP and necrosis can be seen as seen in pilocytic astrocytoma, but that feature cannot be taken to upgrade the tumor. Even in presence of scattered atypical mitosis, it is still graded as CNS WHO grade 1. Chordoid gliomas are rare tumors of the anterior third ventricle, and they are labeled as chordoid because they resemble a routine chordoma wherein the cells are arranged in the form of cord against a strong myxoid or hyalinized matrix. They will also show bright expression of GFAP and TTF1 nuclear expression. And this particular missense mutation is important to be demonstrated for a definite diagnosis of chordoid glioma. Now, apart from the peculiar morphology, which you all have seen in these tumors, one common thing which is there in these tumors is they all show what are called as MAP kinase pathway alterations. So when you come to pilocytic astrocytoma, the commonest alteration is in the form of BRAF fusion. There can be presence of BRAF V600E mutations and other BRAF alterations. It is associated with NF1, particularly the hypothalamic or optochiasmatic pilocytic astrocytomas. The same holds true also for pylomyxoid and pleomorphic xanthoastrocytomas. They show BRAF alterations, and the CDKN2A2B homozygous deletion is very important to be remembered for pleomorphic xanthoastrocytomas. And it has been shown that the tumors which express this type of homozygous deletion, whether it is grade 2 or grade 3, is known to behave in an aggressive fashion. Tuberous sclerosis 1 and 2 mutations are seen in subependymal giant cell astrocytoma, whereas chordoid gliomas show the PRKCA mutations. So all these mutations are can be identified in these tumors with the help of various technical platforms. So the most easily available platform for the neuropathologist is immunohistochemistry. So the BRAF V600E, particularly a monoclonal surrogate antibody, is available for this particular mutation, and it shows us a very diffuse, strong cytoplasmic expression which can pick up the molecular phenotype with the help of IHC. For the BRAF fusion and the CDKN2A2B homozygous deletion, we usually do fluorescence in situ hybridization. And apart from that, we can use other platforms like ddPCR, next generation sequencing, and of course, DNA methylation profile for the diagnosis of these molecular alterations. Now, this is a diagrammatic depiction to see the prevalence of these type of mutations according to the location in these circumscribed gliomas. So if you concentrate on the posterior fossa or infratentorial pilocytic astrocytomas, the commonest molecular abnormality is the BRAF-KIA fusion. Whereas for the supratentorial pilocytic astrocytomas, they commonly see the BRAF V600E type of mutations. So the molecular phenotype of the tumor also changes according to the location of these tumors in the category of circumscribed astrocytic gliomas. Now, why is it important to know all this? Because when it comes to circumscribed astrocytic gliomas, since they are circumscribed and if they are situated in a resectable area, then the most important prognostic factor everybody should remember is the extent of tumor resection. So long as there is gross total resection, the 5-year survival of these tumors is very good and the chances of recurrence are minimal. But if the tumor is located in a difficult area wherein GTR of these tumors is difficult, in such cases, the molecular phenotype plays a very high role in deciding the prognosis as well as postoperative management of these tumors. Now, NF1 tumors, which are located in the optochiasmatic regions, can usually show a benign course, but if they occur in children who are less than 2 years of age in an optic pathway, then they are known to be prone for recurrence and progression. Amongst the BRAF abnormalities, BRAF fusion, that is BRAF-KIA 1549 fusion, is known to show excellent prognosis, and this also has a correlation with the location of the tumors, because majority of these tumors are situated in the cerebellum and fourth ventricle, and that perhaps makes their complete resection easily feasible, and that is why the postoperative recurrence-free survival rate for these patients is very low. In comparison, the BRAF V600E mutation tumors show worst overall survival and a early recurrence post-surgically. And again, to reiterate that pleomorphic xanthoastrocytomas which show CDKN2A, 2B homozygous deletion can show transformation to high-grade gliomas and are aggressive tumors. So this is important to know that these mutations or the molecular abnormalities have a prognostic significance. And of course, there is now a predictive significance to these abnormalities also. So herein you can see that clinical trials have already been established against these molecular markers in the form of targeted treatments, particularly the BRAF V600E. So in case a gross total resection is not possible, then these children have tried to be treated with these targeted treatments, have shown very good response to these therapies. And that is why doing these mutations is also important, maybe for the benefit of medical treatment and to enroll these patients in these clinical trials. So what do we take a message from these circumscribed astrocytic gliomas is morphology is very characteristic, and morphology are the essential diagnostic criteria according to the WHO CNS 5. Molecular markers have not been made an essential criteria. Molecular pathology actually we do not routinely use for diagnosis of these tumors. Suppose I see a 5-year-old boy with a tumor in the posterior fossa or in the ventricle or supratentorial region, and if it shows a classic features of pilocytic astrocytoma, in every case we do not do BRAF alterations. Since in resource constrained settings like in our country or in an institute where all the molecular abnormalities may not be available on technical platforms, the molecular pathology is restricted in case of differential diagnosis. If the tissue sample is inadequate and if the morphologic features are not very clear and characteristic, then we tend to take the help of these molecular abnormalities to make a definite diagnosis of circumscribed astrocytoma and to rule out a diffuse glioma which can have overlapping morphologic features. So with that, I just want to show you two cases for better understanding of these entities. And this one case I have just seen last week. This was an outside referral of a 24-year-old male who presented with a cerebellar signs. The imaging showed a cerebellar mass, and you can see a very classic imaging feature of a cyst with a mural nodule. So herein you can see that normal cerebellum at the bottom and a tumor which is very well circumscribed on the outer aspect of the cerebellum, somewhat arising from the fourth ventricle. Now, unlike a routine pilocytic astrocytoma, this tumor looks more cellular. You can identify the pyloid processes as well as some partially myxoid background, making a diagnosis that this could actually be a pilocytic astrocytoma. What was worrisome in this tumor was there was significant pleomorphism in focal areas, and the eosinophilic granular body was there in one or two sections, which helped us in making a diagnosis of pilocytic. But what about these areas which were looking more cellular, more bizarre, and they were also mitotically active? So here you can see those bizarre looking nuclei which resemble an atypical mitosis. So routinely in a pilocytic astrocytoma, we do not see atypical mitosis so frequently. In this particular tumor, the mitotic count was almost more than 5/10 high power field. So immunohistochemistry was done and GFAP shows or confirms that we are looking at a glial tumor. Ki67, you can see many nuclei are lighting up with Ki67 and it was almost 14%. Normally in a grade 1 pilocytic astrocytoma, it will be 1%. The OLIC2 and the H3K27ME3 was retained. If you can recollect from the last class that H3K27ME3 is a very important marker of diffuse midline gliomas, which also can come in the same location and can show a lot of atypia. But in those tumors, the ME3 will be lost. Whereas in this particular tumor, it was retained, ruling out a diagnosis of a diffuse midline high grade or a grade 4 glioma. The ATRX was also retained. SOX10 is a known immunohistochemical marker for pilocytic astrocytomas, and we take the help of this marker whenever there is a problem in making a diagnosis of pilocytic astrocytoma, and it was very brightly positive in this particular tumor. So this tumor definitely looks like a pilocytic astrocytoma but has features of anaplasia. We did molecular typing, and CDKN2A2B type of homozygous deletion was positive, and this tumor also expressed BRAF-KIA fusion. Both these tests have been done with the help of fluorescence in situ hybridization. So this is what is termed as pilocytic astrocytoma with histologic features of anaplasia. These were the same tumors which in 2016 were termed as anaplastic pilocytic astrocytomas, and some people also refer to these tumors as high-grade astrocytoma with pyloid features. It is important to know that this particular morphology can also be seen in certain percentage of pilocytic astrocytomas, and in these cases doing complete molecular workup as well as the immunohistochemistry is very important. Unlike a routine grade 1 pilocytic astrocytomas, these are aggressive and can recur earlier. The second case, again a pediatric patient, 4-year-old girl who presented with a history of small depression of the bone over the left parietal region associated with headache, and we can see a large mass in the temporo-occipital cortex, a classic morphology of a cystic as well as a solid tumor. On the histopathology showed that these tumor, the cells were arranged in classic rosettes. Now, we were wondering whether this is an actually ependymal type of rosettes, but these were little different from the routine ependymal type of rosettes. So you can see a central vessel and the peripheral arrangement of the cells around the vessel. And at places, the tumor was very hyalinized. So these were different from the routine ependymal rosettes. GFAP was positive, S100 was positive, vimentin was bright, and then MN1 alterations were done. So that's a classic morphology of an MN1 altered astrocytoma. It's the rarest form of circumscribed astrocytic glioma, and the morphologic clues are presence of very stout rosettes and this sclerosis or hyalinized stroma. So this was about astroblastoma, and now it is very important that these MN1 alterations are demonstrated with the help of FISH or other techniques before making a diagnosis of astroblastoma. Now, a certain type of tumors which actually do not come under the category of circumscribed astrocytic gliomas, and they are actually glioneuronal tumors, but are also important from the point of view of pediatric neurosurgery. And these are gangliogliomas, DNETs, and desmoplastic infantile astrocytomas. And these are peculiar in morphology that the glial part of these tumors looks like a pilocytic, but there is an additional neuronal component of these tumors, which is in the form of ganglion cells. So a combination of pilocytic astrocytoma with presence of ganglion cell, perivascular lymphocytes, low ATPA will help in making a diagnosis of ganglioglioma, whereas presence of these floating neurons are important for diagnosis of DNET. I just wanted to bring these tumors also into discussion because the common thing between the circumscribed astrocytic gliomas and these glioneuronal tumors is again their molecular pathology, because these tumors can also show BRAF V600 in mutations. And on immunohistochemistry, it is important to pick up this neuronal component, not to mistake them for circumscribed astrocytic gliomas. So again, to reiterate, it is important to remember the morphology, the common molecular pathways in all these tumors in the form of most common BRAF alterations, and its relevance with respect to prognosis and the behavior of these tumors. Thank you. Dr. Naveen?
Yeah. Thank you, Dr. Megha, for your exhaustive lecture. Is there any questions or any comments in the, anybody has any questions? I think there's no question, Doctor. I think I have one question for you.
Yes.
I think you very clearly mentioned that pilocytic astrocytoma may have some features of vascular proliferation and necrosis.
Correct,
with
sir.
which you can confuse with a high-grade tumor.
Right, sir.
And for that, you do molecular, but not for all cases.
Yes,
So
sir.
is there a number like these many proliferations or these many mitosis, or that's more than number 1 or 5, or as you mentioned in the pilocytic xanthoastrocytoma? So
Right.
then you decide, or even if, like you said, it is seen. So even if you see one also, you do it, or how do you decide about that?
Yeah, so there is a cutoff for the mitotic count, sir. Usually it is more than 5/10 high power field. If we see the mitosis, then we tend to upgrade the tumor and not call it as a CNS WHO grade 1 tumor. When it comes to molecular diagnostic, I think Dr. Shilpa also discussed it last time, that in every case of PXA or in every case of pilocytic, we don't really do BRAF. So suppose if the tumor sample is small, particularly for the posterior fossa tumors, the classic morphologic patterns are not there. In such cases, it helps to do the BRAF fusion, because apart from being a prognostic marker, it is also a very important diagnostic marker. So it is known that every pilocytic astrocytoma will always have BRAF alterations, either in the form of fusion or the mutations. So if you are able to do that fusion protein, particularly the BRAF KIA fusion, then there is no doubt that you are looking at a pilocytic astrocytoma. So whenever there are overlapping morphologic features or the tissue sample is not adequate, is when we tend to take the help of the molecular pathology for diagnosis.
So if they have these features, there are more likelihood of getting a recurrence also.
If there are features of anaplasia like mitotic activity, then of course they need to be treated more aggressively, and then they have a chance of recurrence. So looking at these atypical mitosis, counting the mitosis is very important, not to miss a diagnosis of grade 3 tumor, because when it comes to PXA, and if we see the atypia, then they are automatically upgraded to CNS WHO grade 3 tumors.
One more thing, you mentioned that pilocytic astrocytoma.
Right. Sir.
They are a subtype of pilocytic astrocytoma, which are grade 1, but you label them as grade 2.
No, sir. They are labeled as grade 1 only. In the 2016 and the earlier classification, they were separated from the pilocytic astrocytoma and they were called as grade 2. But now they have been taken under the term of pilocytic only. It is only a subtype of pilocytic, and when we give a diagnosis, when we see pilomyxoid morphology, they will be called as grade 1. But they will be termed as pilomyxoid astrocytoma, not called as pilocytic. And some of the studies which have concentrated on pilomyxoid astrocytomas have shown that in comparison to the pilocytic, they tend to behave more aggressively.
More. So they are type 1 now. Initially they were taken as type 2, but
Type
now
2.
they're taken
But
as
now they
type
are grade 1, not type 1. They are grade 1 and they are a
grade 1.
subtype of pilocytic astrocytoma. Yeah.
Yeah, I think let us see if there's any question. I think they don't have much of the questions over here.
Okay.
So I think if we don't have any questions, I think can we wind up the session?
Sure. So the embryonal tumors is left.
Yeah, I think we can start that, na?
Yeah. Yes, sir.
Yeah, I think we'll start with the embryonal.
Correct. So just 1 minute. Give me 1 minute, sir.
I think
Uh,
you have to share the screen. They have. Is there anybody from the ClearNet?
I think
Yes, sir.
Yeah, I think you, Doctor. Half of the presentation is over. Dr. Megha screen, we need to see this on the screen.
Okay, just allow me a moment.
Yeah.
Hello, ma'am.
yeah, 1 minute. No, I think
Yeah.
I need to.
Yes, ma'am. Your screen is visible.
No.
Yeah, screen is good.
1
Yes.
minute. 1 minute.
Okay. Okay, ma'am.
Just give me 1 minute, please.
Sure, ma'am.
I think yes, we are able to see your.
I'm sorry for the delay. So this is, I'll just cover them in very brief, the embryonal tumors of CNS. And these are basically the malignant, undifferentiated or poorly differentiated tumors, which form actually a very uncommon part of the CNS tumors, less than 1% of the tumors. And these are also have predilection for the young and the pediatric population. There has been a consistent change in the terminology of these tumors over the WHO classification editions. So everybody identified them as medulloblastomas or primitive neuroectodermal tumors and the atypical teratoid rhabdoid tumors. Now, since the molecular genetics has come into vogue, there have been subtypes of these tumors identified, particularly in medulloblastomas and also in the remaining embryonal tumors. And I will come to these tumors with the help of case-based studies. So you can see the change from 2007 to 2021 classification of these embryonal tumors. And you can see the terminology differences which range from morphologic diagnosis to molecular diagnosis. So in particularly medulloblastoma, which is the commonest embryonal tumor, now they are molecularly defined depending on whether they are Wnt activated or SHH and non-Wnt, non-SHH tumors. And the same molecular categories also have come into other embryonal tumors which are other than medulloblastoma, which are now termed as CNS or ATRT and ETMRs, and I will come to these tumors in detail. So the common features of embryonal tumors are they are all malignant small round cell tumors. They are uniformly termed as CNS WHO grade 4 tumors, and that is why they show a very aggressive behavior and they have different molecular pathways. So this is the first case of a 9-year-old boy, and you can see a very well circumscribed tumor in the cerebellar hemisphere, which made him present with cerebellar manifestation. The morphology shows that it's a malignant small round cell tumor, and there are some classic morphologic features in the form of Homer-Wright rosettes, wherein there is a central fibrillary network with peripheral arrangement of the cells around this network. The tumor also shows a lot of bizarre focal morphology with giant cell, presence of necrosis, and what is termed as cellular cannibalism or cell-to-cell wrapping phenomenon, which is a feature of very high-grade anaplasia in these tumors. Routinely for all embryonal tumors will be positive brightly for synaptophysin, which is a very important neuronal marker. And now there is molecular subtyping, which is possible with the help of immunohistochemistry. And these are the stains which are used for subtyping of medulloblastomas, and GAP1 and YAP1 was very brightly positive, and P53 was bright, showing bright diffuse nuclear expression, which made us make a diagnosis of medulloblastoma SHH and P53 mutant, classic subtype CNS WHO grade 4. So amongst the medulloblastomas, now there are histologically defined entities as well as molecularly defined entities. So the commonest type of medulloblastoma is classic, wherein you see small round cells in sheets with infrequent Homer-Wright type of rosettes. In desmoplastic nodular subtype, there are presence of nodules and the internodular zones. The nodules are reticulin free and the internodular zones are very hypercellular and can show high degree of anaplasia. If the nodularity is extensive, then they are termed as medulloblastoma with extensive nodularity, which can be picked up very easily with the reticulin stain. And if the anaplasia is very high in the form of enlarged nuclear size, prominent nucleoli, and cell-to-cell wrapping, they are termed as large cell anaplastic medulloblastomas. Medulloblastomas can uncommonly show a myogenic as well as melanotic differentiation, which is a peculiar morphologic type of medulloblastomas. Apart from morphology, now molecular subtyping is important, and they are divided into 4 groups, particularly the Wnt, which is the best behaving medulloblastoma, the SHH ones, which are intermediate prognosis, and the group 3 and the group 4 tumor, which are the aggressive form of medulloblastomas. The age group and the morphology also varies in correlation with the molecular subtype. Majority of the SHH tumors show desmoplastic nodular morphology, whereas the group 3 and group 4 ones will show large cell anaplastic morphology. Classic morphology is common for all the 4 groups. Now, it is known that this molecular stratification has made a lot of difference to the clinical risk stratification. Simply typing them with the help of only clinical criteria is not enough. It is very important to take into consideration the histologic feature as well as the molecular features of these tumors to classify them into high risk, average risk, and the low risk medulloblastomas. So the desmoplastic nodular and the Wnt ones will come in the intermediate and the low risk tumors, whereas the anaplastic, large cell anaplastic, and the group 3, group 4 tumors come into the high risk morphology. And this risk stratification is very, very important for management or the post-operative management of these tumors, because depending on the molecular subtype and the histopathology, the dose of the radiation as well as the chemotherapy and the extent of radiation will differ, whether it is a Wnt or a SHH or a group 3, group 4 tumors. And it is not difficult to apply this molecular pathology with the help of simple techniques. As I said, that immunohistochemistry is a very easy technique which can be used for molecular stratification. And so we have now monoclonal antibodies which can help in these molecular subtypes of medulloblastomas. So we have shown in many institutes commonly do all these immunohistochemical markers for a definite molecular diagnosis of medulloblastomas. Apart from that, for group 3 and group 4 tumors, we can add a FISH and a sequencing for subtyping into group 3 and group 4 tumors. Now, what is the bearing of knowing all this pathology to the neurosurgeons? Because whenever there is a diagnosis of medulloblastoma with the pediatric age group and the classic imaging, then surgical resection is still the first modality of the treatment. It is important to remember that for those tumors which cannot be completely resected, obtaining sufficient tissue at surgery is very important, because as I have told that molecular subtyping as well as the histopathologic type of these medulloblastomas are important for risk stratification, and risk stratification will decide what kind of treatment they are going to receive post-operatively. So there is an algorithm of diagnosis of these tumors depending on the morphology and the various immunohistochemical stains, and it is important to give a definite grade and a type diagnosis in these tumors. A second case in a pediatric age group, now a supratentorial tumor. Again, you can see it's a very high grade tumor causing perilesional edema and mass effect. And this was also looking like sheets of round cells, but there is a little difference to those round cells in the form of what is termed as a rhabdoid morphology. So these cells show abundant eosinophilic cytoplasm with an eccentric nucleus, and they express various phenotypes in the form of glial GFAP, epithelial phenotype in the form of EMA and Vimentic. And the most important clue to the diagnosis to these tumors, in addition to the rhabdoid morphology, is loss of INI1 immunohistochemistry. The control for INI1 is normal cells and the endothelial cells, whereas tumor cells will show loss of nuclear expression, which is an indicator of SMARCA1 mutations. And with that, the diagnosis atypical teratoid rhabdoid tumor. This is also a grade 4 type of embryonal tumor. And it is important to show the loss of INI1 expression, which is a marker of SMARCB1 mutations. Unlike medulloblastomas, these type of tumors are known to be very, very aggressive tumors. The CNS WHO5 subtypes them into 3 different molecular subtypes depending on the underlying molecular abnormalities and very important prognostic information. So again, these tumors are treated with safe resections followed by the chemoradiation. Another example of a pediatric tumor in the supratentorial region, cystic and solid areas. And this tumor actually looked like an ependymoma and was showing ependymal type of perivascular rosettes. And we thought that being a pediatric supratentorial tumor, this could actually be an ependymoma. It was necrotic, and also showing mitotic activity like perhaps a grade 3 ependymoma. But to our surprise, the glial marker GFAP as well as EMA, which are important immunohistochemistry markers, were negative in this tumor, whereas the tumor actually expressed neuronal markers, which was NEUN and OLIC2 with a very high proliferation index. And again, synaptophysin was very bright, and we did a BCOR immunohistochemical stain. So this is a newly described entity in the CNS WHO 5 classification, which is termed as CNS embryonal tumor with BCOR internal tandem duplications. Now, everybody actually refers to these tumors, or what are they better termed as, are supratentorial PNETs. So the neurosurgeons identify the infratentorial embryonal tumors as medulloblastomas, whereas supratentorial ones were termed as PNET. But now this particular terminology is obsolete because there are 4 subtypes of these tumors which have come forth with the help of molecular phenotypes, the BCOR, the FOXR2, and the MN1 altered. And these tumors also has correlation with morphology. And these tumors are also aggressive type of CNS embryonal tumors. They can occur in supratentorial as well as infratentorial region. And molecular typing is important because the targeted treatments are coming forth for the benefit of these patients. There are certain site-specific embryonal tumors like pineoblastomas, and it has been known that non-pineal CNS PNETs have poorer outcomes compared to medulloblastomas, with high progression-free survival and a low overall survival rate. These tumors can disseminate through CSF and can show drop metastasis in the spinal cord also. The last and the rarest form of embryonal tumor are what are termed as embryonal tumor with multi-layer rosettes. They are called as multi-layered rosettes because of the peculiar pattern of rosettes in the form of multi-layering of the cells. There can be a central canal or a vessel in the center of these rosettes, and the immunohistochemical diagnosis is with the help of LIN28A. They show Dicer germline alterations. These are the same tumors which were earlier referred to as ependymoblastomas or medulloepitheliomas or etanter, but now all these type morphologic subtypes have shown a common molecular phenotype in the form of these mutations, and that is why they are now grouped under one category of tumors which are called as embryonal tumor with multi-layered rosettes. And identification of this morphology as well as genetic alterations in the form of C19MC or Dicer1 is important for a diagnosis of these tumors. The last case is of a pineal gland tumor. You can see a tumor in the posterior third ventricle region in a 5-year-old boy. And this again looks like a small blue round cell tumor. Little bit of ATPR positivity for synaptophysin and a Ki67 is very high. So this is a location-specific tumor. Pineoblastoma is also a type of CNS embryonal tumor and is graded as grade 4. Not to forget an important tumor which is not actually a part of primary central CNS embryonal tumors, but can be seen in CNS in the bone as well as in the parenchyma, are what are termed as peripheral type of PNETs, which also can show a small round cell morphology. But unlike the central PNETs, they express markers of peripheral PNET in the form of CD99 NKX.2, and they show EWS alterations on molecular studies. So this is a peripheral type of PNET which can be seen in central nervous system. So that was an overview of all the CNS embryonal tumors. Now it is important to remember that morphologically they look like blue round cell. Their molecular typing is different, and we have to do the molecular typing to differentiate them. Though they all come under the category of CNS WHO grade 4, within that grade or the type also, the behavior of these tumors is different. The postoperative treatment of these tumors is different, and that is why it is important to subtype them into each different group and not lump them only as CNS embryonal tumors. But if all the molecular workup is not available in the institute, then you can term them as NOS, and it can be sent to a referral center for a definite diagnosis. So molecular genetics has refined the classification of these tumors. It gives a very important prognostic and predictive information. Targeted treatments are being exploited for the treatment of these tumors, but still histopathology is very important for the diagnosis. Thank you.
Thank you, Dr. Megha, for your lecture. It was very elaborate and I think it was very simplified also. So if there are any questions or comments, so I have one question for you. You said about the peripheral PNET. So
Right.
are they the part of the center in which there is drop mets or they are a separate identity in itself?
So that's a very important question. So they can be a part of metastasis. Like this child can have an Ewing sarcoma of the bone and it can throw metastasis to the skull bone or to the parenchyma. But even without a metastatic lesion, primary peripheral type of Ewing sarcomas can also occur in the CNS. They are not very common, but they need to be differentiated from the central PNETs because the treatment for these tumors is different from the central PNETs. So they show that CD99 positivity and EWS are rearrangements, and that is why it is important to make a diagnosis of peripheral PNET away from a central PNET. So we have seen a few cases. There are reports in the published literature that they can occur in CNS. So majority of these tumors actually we see in spinal cord. So particularly if we see a spinal cord round cell tumor, then we have to keep a peripheral type of PNET in the mind. Whereas the other tumors which I showed, the medulloblastoma, the ETMR, the embryonal tumor with FOXR and BCOR, they are known to be more common in the brain. Whereas the peripheral type of PNETs are the tumors which come more in the spinal cord. So that way there is a change in the location, difference in the location also.
I think one more. How often do you see ATRT in the supratentorial compartment?
They are known in supratentorial, sir, both supratentorial as well as infratentorial compartment. So rhabdoid morphology is very important. And one more dictum for embryonal tumors is whatever is the embryonal tumor, it is important to run INI1 immunohistochemistry. So if the morphology clue for ATRT are those rhabdoid cells, but sometimes those rhabdoid cells will not be there. So if you see an embryonal tumor either in the infratentorial or the supratentorial compartment, you have to include INI1 as a part of your immunohistochemical panel. So we have seen cases wherein it resembles a neuroblastoma of the CNS or a medulloblastoma, but actually the INI1 is lost. And in such cases, we have to reterm them as ATRTs. So they are known ubiquitously in the supratentorial and infratentorial compartment.
Okay, I think if we have no more questions, I think we will close the session. So I thank you, Dr. Megha.
Dr. Shilpa has joined. Shilpa, you want to say or add anything?
Hello.
Hello, good evening.
Yeah, good evening. Good evening. Sorry. Yeah, nothing. It was all very clear. I think ma'am has explained everything very nicely. So we can, wrap up.
Okay. Thank you, Dr. Megha, for your time and I think for your efforts. Thank you, Dr. Shilpa. If there are no questions, I think we close. Good evening and thank you all. Thank you, Clearnet also. Thank you.
Thank you so much to all the delegates for extending us the opportunity to host the session. And I hope you all had a seamless experience. So with all due permission, I'm closing the session for today and looking forward to host you again. Thank you so much.
Thank you.
Thank you, sir.